Thank you all for joining us for today's webinar on frequently asked questions regarding cervical cancer screening guidelines. My name is Jessica Monmany, and I'm the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive your continuing education credits. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please go back to the registration confirmation that you received earlier. You can also use the chat box to enter questions throughout the webinar, which our presenters will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from ARHP's education team with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you learned during this webinar into your work. Completing the pre- and post-test, as well as the follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Erica Pettigrew and Nicole Gettings, today's presenters. Erica Pettigrew is a primary care physician, board certified in both family medicine and preventive medicine, in addition to holding a law degree and an MPH. She is on faculty at the University of North Carolina's Department of Family Medicine and is also the medical director of Orange County Health Department. Nicole Gettings has been providing comprehensive reproductive health services in the heart of Midtown Memphis for 10 years. She has a master's in nursing from Vanderbilt University School of Nursing and is a certified nurse midwife with board certification from the American College of Nurse Midwives. She is also a speaker and educator and provides lectures across a broad array of reproductive and sexual health specialties to other clinicians throughout the United States. We're thrilled to have them with us today, and now I will hand it over to Nicole. Nicole, you have the floor.
Great, thanks. So just as a acknowledgement and thankful for the grant money that made this possible came from Roche. Roche is the company that makes one of the HPV testing that we will talk about today. And from disclosures, so the committee that has worked on this PowerPoint as well as a whole series of webinars on cervical cancer screening in the current year is listed here, and there's no disclosures from anyone on the team. These are our learning objectives. I don't usually read them out loud. I mentioned that we've done a whole series of webinars before. It's really starting in, I think, January, that can be located at arhp.org. And with all of these, our learning objectives have really been to try to clarify the changes and the updates that have happened in cervical cancer screening, and help other providers out there understand what those guidelines may mean for their patients, and then also to help folks recognize and realize that there are some populations that are more impacted by cervical cancer for a variety of reasons, and how we can help meet their needs. So the way that this particular webinar is going to work is a little different. We're going to do less content and data, and we're going to focus more on just some questions that are commonly asked questions, and Eric and I will be going back and forth and answering these various questions. These are questions that have come up throughout the series of cervical cancer webinars that we've done. So one of the questions is, how is HPV related to cervical cancer? So we know that almost all cervical cancers are related to persistent long-term, so long-term being defined as usually greater than 10 years, infection of certain types of HPV. We also know that almost all people are exposed to HPV at some point in their life, and that most people will in fact contract HPV. And a very small percentage of people will end up developing cancer that's directly related to HPV. And in 2007, the International Agency for the Research on Cancer, which is the IARC, we'll talk about them a little bit, released a monograph on HPV, and that's really where they collated all of the studies from around the world that were a variety of case controls, prospective cohort series, and case series that really demonstrated the definitive link between specific HPV types, specifically high-risk HPV, and cervical cancer. And then in addition to that publication, there was a series of articles here in the United States. Some of them were published in 2003 in the Journal of National Cancer Institute, as well as some additional articles in 2006 published in the Journal of Vaccine. Many of these were authored by Munaz and Kastelisk and other colleagues. And that whole series really explores the depth of knowledge that we understand about the etiology, prevalence, and cofactors that HPV requires to result in cancer. So how does it work, and how long does it take for HPV infection to result in cancer? So the way HPV works is that you contract HPV from another person from skin-to-skin contact and friction. The majority of people shed this without having any long-term problems within 2 years of initial exposure. For a few people, they never shed the virus effectively, and the virus continues to replicate in their epithelial or skin cells. And over time, the HPV virus actually changes the genetic code of the epithelial cell by essentially turning off the tumor suppression gene. And once that tumor suppression gene is turned off, then the epithelial cell will continue to replicate without apoptosis, so without programmed cell death. And of course, anytime that happens, then that is what we term cancer in any type of cell. That is an ideal situation for the HPV virus because the cell keeps replicating, and with each replication, the HPV cell continues to be, HPV virus continues to be replicated. Unfortunately, that doesn't work very well for us.
All right. So hello, everyone. This is Erica Pettigrew. I appreciate being invited on. So the next question is, at what age do the guidelines recommend starting to screen patients for cervical cancer? So in 2012, the ASCCP, which is the American Society for Colposcopy and Cervical Pathology, as well as ACOG, American College of OBGYN, and the American Cancer Society, as well as the USPSTF, the U.S. Preventive Task Force, all recommended that screening start no earlier than age 21. And this is regardless of age of onset of sexual activity. And you can read these guidelines. These are the major guidelines that most people on the call are probably familiar with. And they can be found at www.asccp.org. So another question we got is, how is management different for patients aged 21 to 24 years? And if you look at the guidelines, they explain that because cervical cancer risk remains very low through age 25 years, as well as the fact that HPV is very common in this age range, they recommend that these patients be screened with cytology alone without HPV co-testing or reflex testing. And we'll get into the differences in those terms in a little bit.
Great. Sorry, guys. Sometimes we're not sure if we're moving the screen or not, so we're sorry for a little bit of back and forth there. So another question that comes up a lot is, should immunocompromised patients be tested at a different interval than non-immunocompromised patients? So this particular question caused lots of concern and lots of kind of a furor, really, in my own community of folks who were long used to guidelines that handled HIV-infected individuals at different screening intervals based on the original 2001 and then 2006 ASCCP guidelines. So oftentimes when I'm chatting with folks, I just like to remind people of exactly what the 2012 ASCCP guidelines said. And they say this, they say that in 2001 guidelines, There were separate recommendations for management of ascus, specific to the women infected with human immunodeficiency virus, or HIV, as well as immunosuppressive conditions. Data review in 2006 eliminated those separate guidelines, and immunosuppressed women with abnormal results should be managed in the same manner as immunocompetent women. So this has been really difficult for folks across the nation to kind of put our heads around, because we certainly don't want to leave our HIV-infected individuals at more risk than our non-HIV infected individuals. And there's lots of back and forth in the data about prevalence and risk for HPV infection and even persistence HPV infection that may differ in HIV-infected women. So just recently, in 2016, ACOG, as well as the panel that creates the guidelines for prevention and treatment of opportunistic infections in HIV-infected adults and adolescents. So both of those organizations released slightly different guidelines just in 2016. So ACOG's were in October of 2016, and these other ones from the panel were in December. So these guidelines kind of went back to the previous guideline. They recommend that cytology screening start with initial diagnosis of HIV, and that this be followed for a few years before you can go to the routine screening advised by ASCCP. So those are brand new recommendations and haven't been out there very long. I haven't had much of an opportunity to really talk with HIV providers about how they're implementing these new protocols and guidelines and how they feel like it plays out. I would really encourage folks to go to those specifically guidelines, so either the ACOG ones or the ones from the panel on the treatment of opportunistic infections, and those are both easily obtained online. All right. Erica, you'll have to remind me. I'm not sure if I'm answering this next one or you as far as... Sorry.
You go and then I go.
Okay, thanks. So HPV co-testing, so what's it mean? So HPV co-testing usually means testing for the presence of HPV virus at the same time as collection of pap smear. There's two general types of HPV tests available. So some types test for low risk or high risk HPV. And then there's a different type. So some recent advances have made HPV testing more specific in that they can actually determine if types 16 or 18 are present. And that's usually referred to as genotyping. So it's a little bit different than co-testing.
Yes, and so the appropriate age to start co-testing, now again, like Nicole just said, co-testing is testing HPV at the time of cytology, is age 30. And so there's no recommendation for co-testing before age 30 for any population.
Yeah. So,
and then, oh, I'm sorry.
No, go ahead, Erica.
I might as well go ahead with, I didn't realize we put this on the same slide. So at what age is appropriate to stop co-testing? Now, the guidelines say start at age 30 and then continue on co-testing until less than age 65, so 64 and younger. And the way to exit routine screening would be if a person had either 3 consecutive negative cytology tests within the last 10 years, or 2 consecutive negative HPV tests within the last 10 years, and at least one of those tests was within the last 5 years, then you can say they successfully graduated from screening and no longer need it once they hit age 65. And this is in women who do not have a history of CIN2 or higher. If they have a history of CIN2 or higher, then the recommendation is to continue co-testing for at least 20 years past the age of diagnosis, even if that pushes that person out beyond age 65. There's a lot higher risk of recurrence of lesions and progression of lesions, and so that's why there's a recommendation for more aggressive testing for those people.
Yeah. All right, so we kind of touched on this question regarding when someone talks about genetic testing, are they referring to high-risk strain testing or type testing? Right, so that's where it gets kind of confusing. So especially because we are all familiar with testing an individual's genetic makeup to determine, for example, if they're more at risk for breast cancer or some types of colon cancer. This is not what we're doing when we test for cervical cancer genetic screening. We're not testing the individual's genetics. What we are testing is we're using a specific test that can determine if genotypes 16 or 18 are present. And then the other types of tests are not testing for those specifically. They're just testing for either low risk or high risk. And the number of specific HPV types that are in the low risk category. I've seen some tests list as many as 30 different HPV types in that category. And so an HPV test that comes back and says this person is positive for low risk HPV and then lists a whole lot of different types that are in there. So that test really isn't genotyping. It's just telling you that one of those, and it's not telling you which one, is present. And that same thing can be applied to the high-risk categories. Usually that list is a little shorter, usually somewhere between 10 and 15 or 20 types. So if it comes back, your lab report comes back and says HPV reflex testing showed positive high risk, and then it lists a whole bunch of numbers after it. Those numbers are the types, the genotypes of HPV, but it's not differentiating between those individual types. So all of that is different than the genetic testing that can differentiate whether 16 and 18 are present. And there's a couple different situations that can be useful. And then some updates we'll talk about in a minute about that specific type of testing and how it can sometimes be used for primary screening. So that's a good place to kind of talk about, well, when is it useful to do HPV testing and in what clinical situations? So one of the clinical situations that's very common is in women over age 30, like Erica referred to earlier, where we have a PAP, the cytology comes back normal, but the HPV high risk versus low risk, so HPV high risk comes back positive. So in this case, HPV genotyping can be quite useful because it's going to determine whether that woman needs repeat co-testing at 12 months or immediate referral to a colposcopy. So if her cytology is normal, her HPV high risk is positive, but you do genotyping and HPV 16 and 18 are not present, then you can just recommend that she return in 12 months for a repeat co-test. If her PAP is normal, her high-risk typing comes back positive, and the genotyping comes back positive for 16 or 18, then you want to go ahead and refer that individual for colposcopy and potential biopsy, because in that situation, this individual is more likely to come back with a CIN 3 or greater on her colposcopy and or biopsy. All right. So Erica, I'll hand it to you for this one.
Thank you, Nicole. So one question we've gotten is, are there any populations for which the guidelines recommend HPV testing without any cytology? Now, the major guidelines that we've been referencing for now do not have any specific populations where a provider should do HPV testing without cytology. But these guidelines are evolving. And so you may be aware that there was an interim report that came out in 2015 which explored the latest FDA-approved HPV test, which right now is the only one that has been approved for primary screening. It's called the COBAS, C-O-B-A-S, HPV test. And so this interim report explored whether and how that particular test could be applied to cervical cancer screening. And so the summary, the take-home from that was, and I'm gonna read this. So because of equivalent or superior effectiveness, primary high-risk HPV screening can be considered as an alternative to current U.S. cytology-based cervical cancer screening methods. Now, it goes on to say, though, that cytology alone, as well as co-testing, remain the screening options specifically recommended in major guidelines. And it goes on to say that while the studies that we do have show that primary HPV screening is just as effective, we still need to do more studies. And so the major guidelines have not adopted this, but and it'd be interesting to know if those of you on the call, if anybody has gone ahead and tested at least some patients with primary HPV testing. I know we haven't adopted that yet in my clinic, but that interim report provides an interesting algorithm. It's almost the inverse of the algorithm we're all used to, where you have cytology that reflexes at times to HPV testing. In this algorithm, they suggest you do the HPV testing, and then if it's positive for 16 and 18, you go on for colposcopy. If it's positive for any of the other high-risk strains, then you actually reflex to cytology, and then if it's negative, then you continue on to your routine intervals. So it's an evolving conversation, but it does look promising that perhaps in the future we will have guidelines that will, major guidelines that will adopt primary HPV screening as a method.
Yeah, thanks, Erica, for explaining that, because that gets super confusing, I know, on my end. I think it's also kind of the other thing that is different than any of these other guidelines we've talked about is suddenly now we're talking in this interim report, as well as the FDA approval, about women that are over age 25. So all of our guidelines up to date have been like 21 to 24, and then 25 to 29, and then 30 and older, and now we're talking about primary HPV screening in women 25 and older, which is sort of, again, reflects that low incidence of cervical cancer rate in women under 24, but it's like a different category now.
Yes, thank you for pointing that out. Yes, exactly. Exactly.
So does co-testing always include genetic testing and or high-risk strains? I think we kind of have gone through this answer, but just as a brief reminder, co-testing does not always involve genetic typing, and genetic typing is not always appropriate when what you really want to do is co-testing. So that's the very short answer. Yep.
So are there populations in which you would not utilize co-testing? And just to reiterate, co-testing is HPV testing at the time of cytology. And so there is no recommendation for anyone to have co-testing under the age of 30. Again, there are some times where you would have reflex testing, but the ASCCP guidelines recommend co-testing for all women 30 to 65 years who fall into the regular screening categories. Cytology alone is sufficient for the first step of screening for people under the age of 30, between 21 and 30.
So when would you use co-testing versus genetic testing? We've sort of been reiterating this, but let's see, so like I said, the co-testing is at the time of cytology. Genetic testing would be when you have a positive HPV test, but it would be helpful to further differentiate whether you have 16 and 18 specifically. And so this might be, depending on the population, if your cytology was ASCUS, then it's helpful to know further genetic testing if somebody needs to go on to colposcopy right away or not.
Yeah, I think, Erica, I'll just chime in. Some of the populations that this also could help with would be if your PAP comes back unsatisfactory. So in the case that there's no transformation zone present, it can help differentiate kind of the next step in management, as well. I'm sorry, I incorrectly said. So unsatisfactory usually means there's just not enough cells there for the pathologist to determine, versus normal but no transformation zone present can be a different result. And in those types of situations, that can also be helpful.
Exactly.
Oh. Okay. So one of the focuses of the this particular series of webinars we have done is really focused on vulnerable populations in LGBT, as well as immigrants, immunosuppressed individuals. We touched on those briefly, but kind of a whole range of individuals who may be facing specific barriers or be at risk. And these really, these kind of questions basically come down to access. So unfortunately, access up until the passage of the Affordable Care Act was often limited for a variety of reasons for people that fell into these vulnerable populations. And of course, this is so timely because we all are probably aware of some recent passage of Affordable Care Act repeal in the House. And this may, in fact, we were seeing some real reversals in these problems with access in these various populations, and we're not sure what's going to happen next with the legislation around this, and it may, in fact, open those barriers back up, and we may see these very vulnerable populations at risk and at higher risk again because of lack of access.
Great. Thank you both for addressing those frequently asked questions in such a great detailed way. We will now begin taking questions live. So if participants could use that question or chat box to enter questions, we will begin answering those now. Our first question is a three-part question, so get ready, and it comes from Rhonda. And it's a three-part question about self-collection for cervical cancer screening. She asks, how does it work? Is it as effective as samples collected by a clinician? And can it be used for both types of PAPs and HPV testing?
Erica, I personally love this question, and I can start, and then if you have stuff to add in.
Go ahead.
So I have long followed the data, and I will share with you that I first started looking at self-collection of PAPs about maybe 5 or 6 years ago. I started looking at it because of the real resistance, particularly in the LGBT population that I served, to having a pelvic exam. And I just started look. Hey, we do GBS collection with self-collection. Can we look at and see if whether or not this is an option? I was thrilled to find out that there were actually a few at that time, I think, and I could misquote this, but I think there were a total of 3 studies out there that I could find that were actually specific products being made to utilize for self-collection of PAP. but there was no other studies out there other than the ones that were specifically from the companies that were making these products. And just in the last year, there's been several studies released, and I don't have them in front of me, but you can certainly go on whatever database searching you normally utilize, and you can look for self-collected PAPs. There have been several new studies released just in the last year that, yes, show good comparison between self-collection versus provider, and that this could be utilized in particularly vulnerable populations. I think at least one of the studies actually uses it in homeless individuals. There's no reason that especially if you're doing the SurePath or, Erica, help me out, I'm forgetting the other name of the other liquid-based.
Of course, my mind is blanking.
It's all right. One of your liquid-based.
Thin prep, yeah.
Yeah, thin prep, there you go. So since you're using the same device there for both your HPV collection and your PAP, you could just use the cider brush for both. So basically you just like with, if you're familiar with doing self-collection of GBS, you just explain to the person how to place the swab inside, as deeply inside as their vagina as they can, and kind of just twirl it around a few times, and then place it in the liquid. And you may need to help explain to them how the thing breaks off, and then to make sure to close the vial, because you don't want it to get knocked over when somebody's nervous or anxious and lose the specimen. And then send it off and see what results you get. And if it's inadequate, you can always have them come back in. And of course, you would want to go through that on the front end. Yeah.
Wow, that was great. We have not instituted that at my clinics yet, but we are still working on self-collection for other things. This seems to be the wave that we're going on, and I think it's really patient-centered, and it's great that the data seems to be supportive.
Yeah, it's really small data, I will say that. I mean, we just don't have big enough studies yet, so yeah. Jessica, what other questions do folks have?
Perfect, thank you. Our next question comes from Cheryl, who asks, what are your recommendations for screening if the patient has already had a hysterectomy for cervical cancer?
Erica, you want to field that one?
Yes. So, so if they have had a hysterectomy for benign reasons, as we said, then they do not need further testing. But I actually, Nicole, you may be more up to date on those with invasive cervical cancer, what the screening guidelines would be, or not screening, but what the follow-up.
Yeah, so the tricky thing about that is just remembering that your oncologist is going to handle that initial, usually for the first 1 to 2 years post-treatment. They're going to handle those screenings. And it will depend on, in most cases, where there's cervical cancer, the primary treatment is that they're going to do a full hysterectomy, and there's not going to be part of the cervix left. And so the oncologist will follow them up, usually the first 1 to 2 years, and then they'll be transferring them out. And usually they are available to answer questions and to go over any specific questions you have. If you have a specific patient that you're like, do I need to do any kind of sample collection? And I would just encourage you that if you have a patient referred back to you in a primary care or GYN setting after they've finished treatment, that you establish open communication with their oncologist and make sure that you're following the recommendations that they were advised.
Great, thank you.
Awesome.
Our next question comes from Mary, who asks, what should a clinician do with a PAP result from a specimen done incorrectly on a teenager? Getting into very specific case-based scenarios here.
Yeah.
What to do when the screening guidelines weren't really followed? So I'll go ahead and take this.
Yeah.
So I have also been there when you look at an abnormal result and realize that perhaps we didn't need to know about it. And so that's something that I would encourage you to keep in mind. And so the reason why we're not screening teenagers is because we know that they often will clear their HPV infections as well as any lesions pretty quickly. And so I wouldn't necessarily change anything. I would make sure that they start their pap smears at age 21. If there's something that obviously is really concerning, you know, if there's an age spill or something like that, then I may consider following up with another pap. But I wouldn't jump on that very aggressively at all. I don't know, Nicole, if you would do anything differently.
No, not at all. I mean, you know, just helping folks, you know, communicating with the patient about why you're not going to follow it aggressively, and, you know, that, but also reassuring them that they do want to get back in and get that normal screening starting at age 21, and just using that for an opportunity to talk about STI screening and how that's different, and use that valuable time that you're now given with this adolescent to talk about things that are going to be important about general sexual health.
That's a great point. Thank you. We have a follow-up question on the self-testing or self-screening. And this is from Miles, who says, I heard you say that the patient needs to insert the cyto brush as far up into the vagina as possible and move it around. Does that generally pick up enough cervical cells for testing, or do you find that you often have to retest?
Sure, that's a great question. Thanks, Miles. So both the data and my own clinical experience has been that I rarely have to retest. That in fact, in the ones that I have submitted, which is a very small number of folks, but in those ones who just, otherwise the answer was going to be they weren't going to have a PAP. They just were really unwilling to get a pelvic exam. I also had one individual that had a congenital physical anomaly, and it was just not possible to reach her cervix, and she was willing to try to do a self-collection. So she didn't fit in that LGBT population, but she had a physical anomaly that made her cervix particularly difficult to access. So in all the ones that I personally have sent, I have gotten back sufficient sample, and the results have been able to then determine what the next step of management was. And you can look for, and Jessica, I know I've sent you follow-up stuff before that you've sent out to people who participate in the call, but I can send you at least one of the resources that is out there and available of a publication here in the U.S., and I believe that it was done in the Appalachians on homeless individuals, that showed good return of self-collected samples as far as adequate cells.
Great, that would be perfect. Thank you. Erica, do you have anything to add from your experience?
I'm eager to learn more myself about the data around self-collection for PAPs. So I have not had any personal experience yet.
All right, well, we look forward to hearing what you experience. Our next question comes from Lisa, who says, some of her patients are so used to getting screened annually that they are skeptical about the longer intervals between testing now. Do you have any suggestions for explaining that change in the guidelines and reassuring them that it really is okay to get tested less frequently?
I'm happy to take that one. So that is also something that I experience a lot as well, especially in the last few or a few years ago. I feel like it's lessened up a bit. It almost feels like there's two categories of patients when they first learn that they don't have to have annual PAPs. Those that look at you very skeptically, and those who are ecstatic that they don't have to do that every year. And so with those that are skeptical, I talk about how these guidelines came to be. I talk about pretty much every major organization, professional group that works on this got together, and they thoroughly looked at every single study. And what they found was that we were testing people way too much, finding things that we didn't need to worry about because the body was going to naturally take care of it, and thus we were doing too many procedures on people that never needed them. And so I do a kind of a very brief couple of sentences just about over-testing and how that's actually harmful. And, you know, I would say, I don't know, 90–95% of the patients are satisfied after that explanation. And sometimes you have the patients who really just feel strongly that they need a PAP every year, and I think that you continue that conversation, but I tend to agree to do it with them understanding what the risks are of them being over-screened.
I think that's a really patient-centered way to do that, you know.
It's tricky when we've told patients one way for decades, and then we're trying to tell them, well, no, actually, we rethought this, and we're going to do it differently now. I understand that that can be somewhat distressing to some patients.
Yeah. I definitely, on my end, I get folks who think that that policy came because we just wanted to save money in healthcare, and helping them understand that no, actually, it's because we were doing more harm with that over-testing. It's not about we were wanting to like go on the cheap. That's not why we've recommended that.
Yeah, that's a really good point too. And I also usually throw in just how the time it takes for cervical cancer to form is many, many years. And so as long as they're getting their screening at the 3 to 5 year intervals, then you know we're going to catch things generally.
Right, right. These have all been great questions, Jessica.
Oh, good. Well, your answers have been fabulous, too. We have another sort of similar counseling question regarding the last slide on barriers to care and how that restricts access. And David wants to know if you have any counseling or cultural sensitivity strategies that you use to mitigate the impact of limited access or other barriers to care in certain populations. Just knowing what physicians, clinicians, anyone who provides care to patients can do in sort of a restricted access environment.
That's a great question. I think I'll say one thing that comes to mind is the disparity we have in our country where women who have lived in the U.S. for usually about less than 10 years are much less likely to have been screened at the proper intervals or the recommended intervals. And so particularly with patients who are immigrants, I often ask them if you know, if they've ever had a Pap smear before and if they've ever heard of it, if they know what it's about. A little bit similar to what I talk about with my 21-year-old patients, but really starting with understanding what the patient's understanding of Pap smears are and why we're doing them and why it's really important is one way that I try to broach that, and I've had all kinds of different answers based on that question. Yeah, that's the first thing that pops into my mind. Nicole, I don't know if you have any other thoughts, particularly with
I love that approach of asking folks what they understand about a PAP and what it's for. You know, I had with the large focus on LGBT folks for me, you know, I met over the years with some community groups that were specific for transgender folks, and one of the messages that they shared with me that was just really invaluable as far as thinking about that was that they really wanted to know that we were really offering services specifically for transgender individuals, that we weren't just grouping them in with LGBT folks, and that, you know, I had kind of assumed that they would not want to be isolated out, that they would want that marketing to be kind of more inclusive of the whole population. And they said, no, actually, we're concerned that our needs would not be met unless we see specific marketing and specific outreach to us as transgender individuals. And that was really an important lesson for me to learn early in starting to change my clinical practices to meet these different needs. You know, regarding access itself, I just, that is a whole can of different things, certainly with the Affordable Care Act, but also in regards to patients feeling safe and cared for, regardless of where they come from or who they identify as. There are lots of trainings out there for LGBT folks. So I think Fenway does one. I know GLAMA, so the Gay and Lesbian Medical Association, they do some training specific to that population. So you may want to look into some of those, as well as, oh, there's one more organization that I use a lot. It has the yellow equal sign as their symbol, and they offer specific training on LGBT folks and clinical care.
Would that be the Human Rights Campaign?
It's not. I know Human Rights Campaign uses that. Just a minute, and I can probably find this.
One question I have for you, Nicole, since we're talking about self-collection, I've been reading more and haven't done it a lot, but offering the patients to place their own speculum if they want to. Have you incorporated that at all into your practice?
Yeah, a little bit. You know, I definitely, you know, I definitely encourage folks to try to use whatever it is that makes the patient most comfortable. And that can be one thing. Another thing can be as simple as letting them just keep their, I always say, let them come in their cowboy boots and keep them on, right? Like you're somehow less naked and vulnerable if you have your cowboy or cowgirl boots on. And there's no reason in the world that they have to take them off to have a pap done. So just kind of thinking about those things, thinking about comfort level with, you know, some folks, it's comforting to have like earphones in and listen to music. Dim your lights. I found over the years I had to install a smaller like corner light that was like on a stand-up light, so that I didn't have to have those awful glaring lights on overhead if that made the patient uncomfortable. So
those are great tips.
Yeah, just all kinds of things to really think about that.
Jessica, do we have any other questions?
We do have one more question from Valerie, who asks if there are any efforts on an antibody blood test for men and women similar to the one for HSV testing or herpes simplex virus.
Ooh. I'm not aware of any. Nicole, are you?
Yeah, that's a great question. So remember that the HPV virus versus the HSV virus, so your herpes simplex, is very different. So HPV, we have known 130 plus types. So that, that would mean that it would be very difficult to differentiate with an antibody blood test on which type of HPV that we see. The other thing to remember with this question is almost everyone contracts HPV. I just would encourage folks to repeat that to yourself. Just like say, I have HPV, you have HPV, we all have HPV. So in fact, doing a blood test to look for antibodies would not make any difference. We all have HPV. the question is one, do we have a specific genotype? However, I would caution you on that because the largest, the most prevalent type of HPV is actually HPV type 16, which if you remember, that's one of the riskier types. However, when it persists for greater than 10 years, that's when we get concerned. So I know that was a long answer to your question. I hope that was helpful in a way to think about why HSV blood antibody testing would be different. It tells us different information. We're only looking for 2 variations of HSV. And even with the HSV, just because you have the antibodies may or may not mean you ever develop symptoms or you ever have lesions, either, you know, on any of your mucosal membranes. So I hope that was helpful.
Yeah, that was
Perfect.
great. Thank you.
Thank you so much. So it's time now to move on to the key points. And Nicole, I'm going to ask you to do the first half here, and then Erica, if you don't mind doing the second half.
Sure. Have you given me mouse control? Oh, perfect. All right, so just in summary, cervical cancer is caused by persistent infection, so 10 to 15 years. Intervals for screening have been revised based on a long accumulation of data, and specifically for the young women under age 25, so 21 to 24-year-olds. There are separate algorithms both for initial screening but also on management of abnormals. And that's really to avoid that over-treatment of HPV infections that they're going to clear and just letting their bodies do that.
Wonderful. So a few more key points, key take-home points. So genotyping can be helpful when you have a discordant, a normal cytology and a positive HPV result in women aged 30 and older. So again, this is the genotyping. So this is, you have a positive high-risk HPV test, and then you're further going to find out if they have 16 and or 18. And then once women who do not have a history of CIN2 or higher reach age 65, they can exit from screening if they've had, again, it's 3 negative consecutive cytologies or 2 consecutive negative HPV tests within the last 10 years, and at least one of those tests must be within the last 5 years. That's how you can say that a woman has been adequately screened and she no longer needs any PAP.
Great, thank you so much, and thank you again for joining us, Nicole and Erica. Before we end today's webinar, I just have a few additional reminders. Be sure to visit arhp.org to view on-demand webinars from earlier in this series listed here. You may also download a copy of this presentation and other presentations by visiting core.arhp.org. As a reminder, you will receive an email from ARHP's education team in about an hour containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing the internet browser. If you have questions, just email us at education@arhp.org. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.